Dr. Foreman, I'm still hearing a lot of beeps with people coming in. So if you're okay, just maybe giving everybody one more minute to hop in the room, and then we can get started if that works for you.
Yep, sure. I think I'll be able to get through this pretty quickly. So I was thinking maybe 3 or 4 minutes if you want to. I'm good with that. I think we should still have plenty of time for questions and such.
Excellent. Thank you.
Sure, no problem. I know how it is to try to rush through getting done with clinic and popping in late. So I'm fine with giving people a few minutes. We probably should just automatically start all meetings at like 5 after, right?
Right.
So,
but keep the invitation the same, right?
That's right. That's right. All right. Well, it seems to have slowed down, Katie. Should we go ahead and get started then?
I think we're good to go. Thank you, everybody, for joining us today for this installment of our Lunch and Learn. Today, I'd like to welcome Dr. Bonnie Foreman, who will be presenting vaccinations in a value-based world to our group. Dr. Foreman joins us as part of the family at Vandalia Health in Preston. So I will turn it over to you, Dr. Foreman. And one little last plug, we do have more Lunch and Learns being planned. So if anyone on this call has a topic they'd like to hear more about, or if you have a topic you feel as though you are an expert and would like to present to the group, please reach out to myself or Eric Cadle on this call, and we would be happy to develop that and into a Lunch and Learn series. So I will hand it over to you, Dr. Foreman. Thanks.
All right. Thank you, Katie. Let me know as I switch this first slide. Are you seeing, is it moving forward here? Give me 1 second. I'm not very tech savvy there. Are we good? Did it move forward for you?
Yes.
Okay. Excellent. Well, thank you for joining us this afternoon. Halfway through the week, halfway through the day, and believe it or not, halfway through the summer. So I guess that puts us halfway through the year's educational series. So very excited to be here and present this to you. I have a picture here of my team, part of my team anyway, at one of our locations in Preston. We are a 25-bed critical access hospital. My clinic that I work with there, Dr. McNair's in the back, if you remember him, if you tuned in last week, given the rabbit ears. We work out of the clinic in the hospital, and we have 3 other additional clinics spotted around Preston County. We have a total of 6 physicians and 4 APPs. We're big on teams, both team-based care and team-based nursing care. So it does take a team to get through health care today. So I'm very appreciative of my team and look forward to learning with you all a little bit today. I did list the objectives here on the screen. As you can see, I'm not a big read back to you on the screen, but we will try to meet these criteria. We'll talk about the vaccines that are measured, some inclusion-exclusion criteria. I saw my new best friend, Dr. Lohace, joined us as she's been helping me navigate. If you're not all aware, across the system, I'm sure most of you are, there are various versions of Cerner, as well as others like myself who has feels like a chisel and stone some days, but CPSI. So how we get these gaps closed are a lot dependent on our technology. So I'm going to attempt to share a little bit about that. And then I also, as we move through this talk, I hope you can put your thinking caps on. I do want to hear from you. Part of what I found when we do these talks is that sharing the information, sharing best practice. I've reached out to some of the individuals, some pediatricians, to get some feedback to kind of start the conversation, but I do really look forward to your feedback. So with that said, this is also going to be a little bit non-traditional. Fortunately, what is measured by our payer partners do align perfectly with the vaccine schedules that you've already been taught. So I'm going to start this talk from the area, assuming that everybody's aware of that. I will put it on the screen, but that everybody has information on it. Everybody knows about that. And we're going to talk about how do we achieve those goals. You know, our goals align with the payers and getting those vaccinations complete. And so went maybe down a few rabbit holes of learning a good bit myself about how we can work together to accomplish all of that. One of the first things I learned here was that there is such thing as a National Vaccine Day. So learning something as we go. I'm also going to make this a little bit interactive as we go through. I've got 3 or 4 questions spaced out to kind of, again, get your feedback, make it a little bit more entertaining, I hope, as well. So with that said, question number 1. Can anybody name the 2 diseases that have been completely eradicated by vaccination? And I figure I gave you an automatic cheat sheet with the electron microscope picture of those. Anybody have an idea there?
Smallpox and polio.
So 50%. Polio is not quite yet, but you are completely correct in smallpox. And it was actually a trick question. Because the other one that I found, again, in my data or in my literature search, was rinderpest. So that was a cattle plague. But it still speaks to the fact that vaccines can completely eradicate disease. Again, most of you probably would have guessed smallpox. Just some background facts. Again, part of what I'm doing is building on the future and giving you, on the end of this, the future in this discussion. But part of that is arming you with data. Interesting facts. I was not aware that we still store strains in the freezer at the CDC in Atlanta and in Siberia. Janet Parker was our last person that I could find that had passed of smallpox, and it was declared officially eradicated in 1980. The other key piece on this slide that I want you to pay attention to is the seasonal and regional epidemics in the 20th century caused an estimated 300 to 500 million deaths worldwide. These large numbers are going to be important as we move forward in this discussion. So let's get straight to some straightforward parts here. This is a very straightforward section. We're going to break it up with childhood, adolescent, and then adult. So in childhood, this is what's directly from our payer partners, our programs that we're involved. And I know it's probably in a little bit different format than you're used to looking at in your vaccination schedules, but they do align perfectly. Do keep in mind, again, this is completely aligns with the dosing schedules, but just so they are laid out from the payers as well, reminding timing is going to be important when you do those vaccines. But again, this all completely aligns with what is the recommended dosing schedules. Here's where it gets a little bit more tricky. Is this piece of recording your efforts, making documentation in the state registry as well as in your medical record. And again, I kind of alluded to this earlier. We really need to have technology that is able to then document and give the feedback based upon what we're documenting. So we need to focus on doing our part, and then we have a team, I believe, that's pretty strong here at Vandalia Health that's working on that process of helping our technology and our teams to work for us. So these are all things you would expect. I think we are all probably aware you just can't say it's up to date. You have to provide the additional facts there for that. Also straight out of the manual, so to speak, is the exclusion and criteria. I've listed those. Again, this would all be, I think, pretty straightforward and as expected. I will have a little reminder there at the bottom. Two things. One, don't lose any sleep. I found this slightly maybe dark humor of mine. But if you're enrolled in hospice or you're a member who passes away, you will not hurt the data. So you will be, that is counted as an exclusion measure. I found that a little bit dark that we listed that out, but it is in there. And then also remember when you're documenting in the medical record, of course, some contraindications are vaccine specific. So it would be important to have that linked to the specific vaccine. All right. I also included for anyone with our billing teams and such, again, this is all pretty straightforward, but all the codes that should be linked. So again, this is the pretty straightforward part of the conversation. So question number 2. What vaccine preventable disease has killed the most human? And I'm giving you 2 hints on this one. One, this is data from 2018. I'm going to be talking about here on these next couple of slides a paper published in 2018. And so we're not discussing COVID. And again, I gave you pictures of multiple illnesses. So if you had to guess, or maybe you know, what vaccine preventable disease has killed the most human as of 2018?
I want to guess the flu.
Influenza. Okay, anybody else? Most of the time it is actually strep pneumonia for the win, sadly, or the loss, however way you look at it there. So this was from a paper published in 2018. It gives you the global estimate of annual vaccine preventable deaths in children less than 5 years of age in order of their prevalence. So you can see, so indeed strep was the highest, but also I want you to keep an eye on that measles. As you know, we had a case in West Virginia now, so that'll be important later on. Measles is at 74,000. And again, this is global. So with that, and again, the reasons for this will come about further on in the talk, but I wanted you to have a concept of how many people we're talking about here. So in this paper, 2018, they estimated the total world population of children under the age of 5 was 679 million. Of those 679 million children, all-cause mortality accounted 5.3 million. So all causes 5.3. Vaccine preventable deaths was 700,000. So then I said, that's a big number, but how can I better display, or how can I better talk to my patient about 700,000, the concept? So I thought of the WVU football stadium in West Virginia. I think most people have either been there or seen it or have a concept of a football stadium. The average attendance in 2023 was 53,000. So that's basically, if you take 2 seasons of all home games, all attendees, gives you a rough estimate of 700,000. So that again is worldwide, but it's I thought it spoke volumes. I will note, I gave a little nod here because they did bring up, again, if you listen to Dr. McNair's talk last month on the social determinants of health, 99% live in low to middle income countries. So just some numbers. All right, back to immunization of adolescents. Again, this is another very straightforward part. There are absolutely no surprises. It goes along with what you expect from the tables that you are used to seeing. So all that is very straightforward. I did give a couple caveats here. On the guidelines, the minimum time between the two HPV vaccines is 100.
Child home?
Yeah, he's home.
Is 100.
Does somebody want to mute themselves?
What matter?
Is 146 days, but remember the recommendation is actually 6 months, the 168. So that's just a little caveat. I threw in the reasoning for the 3 dose series, and also just remember or keep in mind the meningitis B does not count toward those metrics, and you do need a booster there at 16. But again, that's all pretty straightforward. Again, back to the same as with the childhood, recording your efforts. We're going to talk about that and how we do that at our different EMRs a bit later on. But those are all the same. And exclusion criteria, again, please document those. We need to be capturing those. And again, never be in doubt. If you pass away or you're in hospice, you will not hurt the data. Again, I included the codes. And I'm assuming we're going to share out this slide deck if I'm moving a little bit fast through here, but if you have them. All right, question number 3. This is probably the biggest area that I found most important, that it's not straightforward, it's not simple in the tables, and it's something I think we've had the greatest challenge, at least for me when I look back over my total career, is I did some digging into what are the reasons that we're not vaccinating. And I think if we understand those reasons, we may be able to improve our vaccination rates. So can anybody throw out any, I kind of classified them as the data did on, there are 4 major reasons. Can anybody throw out any of the reasons you might have heard patients mention why they're kind of hesitant to vaccinate?
Misinformation and or lack of information.
Oh boy, Tammy, excellent, excellent. That's probably I find that one probably the most important one to us, and we're going to talk about it. Anything else? What are the other things that you hear of, even with flu or anything? Religious reasons, yes. So we've gotten 2 out of 4, definitely. Any more? Somebody put that in the chat. I don't know if that pops up on everybody's screen.
Or medical history.
Medical history, meaning they've had a bad outcome in the past themselves?
Yeah.
Okay, yeah. Okay, all right, so I'm going to break them down in no particular order, but I am going to end up with the one that I think that we can impact the most. So number 1 is, the first one mentioned again in no particular order, is religious reasons. There are, from what, again, this was a paper around 2018, 2020. I kind of intentionally stayed out of the COVID realm. But at that point, about 4 states did offer exemption. The key part that I got out of this research was that this is not a byproduct of ignorance. It is rather an intentional and calculated decision related to a staunch conviction. So I've kind of got that feeling that might be something that we as providers have thought. But indeed, when this came from data where they interviewed many patients, many families, many parents who did not want to be vaccinated. Now, the biggest problem with this one is it tends to be linked to refusal of all vaccines, and it doesn't just affect one. Again, to correlate disease prevalence with vaccination rates. Countries that have higher exemption rates do have higher. This example was pertussis, but I think we can find similarities across. So what the other point that I gained out of this was when they really drilled into the data and said, well, what about it is causing this religious reasoning? And many, the majority related to the animal-derived gelatin used in the production as well as human fetal tissue. So the thought on the why behind this data was, if we can understand as a scientific community what is driving those religious motivators, could we focus areas of research on alternatives that work around that don't require these products or these associations? So just something we can't individually, but I think being aware of it, and if we drill down with your individual patients that they have a specific concern, you may not be able to get them to universally vaccinate, but it may be selective, which some may be better than none. So a thought on that one. The second bucket described is personal beliefs or philosophical reasons. Only a handful of states allow that, but this goes back to what you all talked about earlier about some misinformation, disinformation. But folks believe that your natural immunity may be better, or that if they get the actual disease, not the vaccine, it's going to make them stronger. This was why I brought up a bunch of those numbers earlier, and I'll continue to do so because this is another repetitively theme, is that they feel that these diseases that we're talking about are not very prevalent and that they're easily treated and they're not life-threatening. And so because of that misinformation, they're making those decisions. They also believe if you just have a healthy lifestyle, it's going to decrease your risk, which is always a great idea, but is not going to do what a vaccine will do. I think some of you alluded to safety concerns, and this one was a very highly rated. The concerning factor here, and this will go with reason group number 4, is that in the absence of a solid relationship with their provider that they trust, and in the absence of easy to understand information, the majority of patients that fall in this category will fall back on what their friends, neighbors, and media say and take that for gospel. One of the biggest ones cited was the thimerosal. I'm sure a lot of you have heard about that, but it's been over a decade now since that has been removed. Also, the fears then lead to the delay in the vaccinations, which one of my pediatric colleagues, Dr. Pumphrey, brought up was, all the studies have been done using the vaccine schedule, so our hope for success in decreasing prevalence of disease is going to be directly related to having those vaccines at the prescribed interval. Safety risk was a greater concern, and then also the healthy relationship and trust with the provider is very important. So this is the area, the fourth bucket is the one that I think we as providers can be, and as members of a healthcare team can do the most good. And this is the desire for more information. So 1/3 of study participants in this reported that it was the lack of access to sufficient information, and they did not think that their provider was easy to talk to. 1/3. So that's a pretty large number. They want easily presented facts. They want to be able to understand the risk and benefits and make that decision for themselves and for their family members. And they want detailed information. They just don't want it to listen to because I said so. So I think that also goes along with the good relationship, feeling like they can have a conversation and not be judged. So these next slides, I think, are the most important. I went through and compiled, and again, we'll give you these. And I've actually tried this since I did this research over the past couple of months. I've handed this to a couple patients. So I'm going to give you a lot of different options here. This is directly from the American Academy of Pediatrics. These hyperlinks on the top. So this one for adolescent immunization. If you click on that, you're going to see a screen that comes up, and it's going to show you a little square like the picture at the bottom. and it has every adolescent vaccine. And on that, you can choose multiple languages, and you can choose whether you're going to use this as a patient handout or as a provider quick reference sheet. So there's a pretty much a one-page information if you need to brush up on, hey, all these details, which it's great. But there's also this really neat handout like this one presented. I thought that a lot of our young patients, young parents, it's got QR codes, it's got things laid out so they can see it. So this is that's what's presented by the American Academy of Pediatrics. Go on and play with that. I haven't got to follow up with my patients that I gave that yet, so I'll be interested to see how they do. This is an example. I just kind of cut a snippet off from healthychildren.org, and they link it again, or they lay out their pages also. This is the chicken pox. They give you a little bit of brief information. They talk about safety, if you're breastfeeding, always that autism link, and then where to find more information. So that's from that healthychildren.org. This one is, I again kind of went down a rabbit hole and wanted to provide you with that information. So as mentioned earlier, one of the big categories is they don't believe that these illnesses are dangerous. They don't believe that they're very prevalent. So if you have that person or you just have an interest in that, there is a book I found, Adverse Events Associated with Childhood Vaccines, Evidence Bearing on Causality. And all my references are cited at the back. So this is an entire book on causality of adverse effects from vaccines. I also did some digging into how have we always monitored, right? So we originally had the monitoring system for adverse events. But since I believe it's 1990, we have the vaccine adverse event reporting system. And I got on that site. So the key with it is that it is a US based, and it does accept and analyze adverse events, but this one isn't only from physicians. This one, any person, a parent, anybody can report. It is a big database, and you can go online, you can figure out how to navigate it and find all kind of information. So as deep as you want to dive into it. But I did give you another example. I pulled up measles again because we just had that case, so I thought it might be more relevant. If you do the math and you look at my earlier slide, between 1979 and 1990, when we just had the monitoring system for adverse events, which was primarily a physician provider driven system, they found 27 deaths that could have possibly been linked to a vaccine. When you add in 1990 to 92, when we started using VIRS, we caught another 32. So again, I found that interesting in that anybody can submit. So you probably are having more submissions and more things researched. But again, if you add that all together from 1979 to 1992, that was 59 cases. Okay. But if you go back to that slide that I showed earlier, 2018, average deaths per year worldwide for measles from the disease, the deaths, not the cases, was over 74,000. Okay. And then if you go down to before the measles vaccine program began in the 1960s, and just in the US, there were 3 to 4 million cases and 500 resulting in deaths. So I'm not saying I guess I am kind of saying a few deaths are better than many, many deaths, which is none are good, but the numbers are just even greater just in the measles situation than I had first imagined. Some additional resources, I kind of put them on one page there. There's the West Virginia Rural Health.org, immunize.org, the other two sources that we talked about. And then always I try to, I think the biggest thing is having that conversation with the healthcare provider. But that just definitely made me aware that maybe I wasn't doing quite as good a job as I thought I was at having these conversations and communicating. So food for thought if you're in that category. So adult vaccines. As mentioned on this slide, none of our current value-based agreements have an adult vaccination as a scored measure in 24. However, of course, there are HEDIS measures, so I added that in. And now I'm going to move in. I'm going to start talking about our different EMRs and how we're documenting. And so I'm giving the disclaimer. I'm hoping Dr. Lohace can chime in if I really mess this up. I use a system again, an old archaic system called CPSI. It's kind of like the hammer and chisel compared to what those of you who are in the South and have that Cerner product. I think the different individuals throughout the North who have the different products, we all have our issues. I did want to share with you, I've gone down and worked with Dr. Lohace and saw how she has been optimizing what you have in the South. So I wanted to share that out with everybody just because at some point we will all be on the same platform, and I think that's very beneficial. So Dr. Pam George and her team are putting subject experts around each of us in the North based on what EMR you have to help drill down and work on these gap closures and doing a better job of finding out where our EMRs aren't doing the best at optimization. So I was super excited to see what all Dr. Lohace does. But remember, I'm sharing with you information about an EMR I don't actually use. So hopefully I won't mess this up, and hopefully it will have some information that will be beneficial for you. And if we get it to the end, I'll open it up for questions and we can flip back and talk about some of this. So this completely was something that excited me. And I know we are starting to use these handheld scanners in the North. So if you do have Cerner in the South, there are this QR code scanning. So the vaccines are logged in the pharmacy. As the nursing staff administers them, if they use the scanner, it automatically is going to populate into your EMR, all that information that we need. And then we're also going to talk about the two-way interface you have with the West Virginia SIS. So we can make sure that both documents have the correct updated information, and it takes away any of that manualness to it. So I'm very excited about that. And then also a little note here about enrolling in the VFC program, which is free of charge. Something else I learned from Dr. Lohace and team, and we're all sharing information, is the influenza exclusion. So there is a code that can be dropped for that as well. So sorry, I'm jumping around just a smidge here. As we talk more about the gap closure, I kind of already mentioned, we have health coaches, we have Pam and her team, we have our EMRs, and the Healthy Intent platform as well. So I'm going to give you a few more examples from the South. This is an example of what you will see, I believe, this is a 9-year-old who didn't receive their influenza vaccine. And so you're able to see under your immunizations tab that that's going to be due. You will have a view forecaster, which is nice. I don't have anything like this in CPSI, that it's pretty much going to give you a cheat sheet and a preview that tells you what you're due for and when. So that's a nice feature. Here is a slide on the interface between the West Virginia SIS and how you're able to, you must confirm, but you're able to reconcile with your immunization in your EMR. And then those two, if you look at both, they are correct. You can pull the two so that they will be, again, uploaded automatically into your EMR, which could be very beneficial. Ours is very spotty as to whether it does that or not. This was an amazing feature that I'm very excited about. So in this, it talks about your Healthy Registries tab basically looks at risk factors based upon your other diagnosis and aligning it outside of the CDC schedule. So this was an example that she gave me of a rheumatoid arthritis patient on an immunosuppressive medication, and it flagged that Shingrix would be indicated. So again, you have to confirm and use your brain and think about this. Don't just follow the computer, but to flag us, to help us to better cover our patients. I think this is awesome. Another feature that I so look forward to is when you're doing your Medicare annual wellness visits, you can see, and it'll be laid out, which sections are vaccines that are required based on diagnosis that we can give in the clinic. And then also this shows which are prescriptions for vaccines that can be sent to the pharmacy. So again, this is kind of small. I'm betting if you're having a little bit of hard time seeing it on the screen, I apologize, but we'll include those slides. But I think that will be another beneficial event. And then also, if you give an immunization, again, this is with our Cerner friends in the South, if you give an immunization or a prescription during a visit, it automatically populates into their assessment and plan under the diagnosis, and they have a visit summary to send home with the patient. A note back to the G code for the flu vaccine as we move into the fall. Dr. Lohay says that they have initiated an auto drop for that code, for that charge in the code, and that will take them out of the denominator. So that will improve our measures, and that outline has been submitted to IT. So I'm sure we'll be able to relay out to individuals how that's going. So again, I'm excited about a lot of these features. My EMR in the North doesn't have any of this. So I think this gives us a preview. If you're on a different Cerner platform, Pam and Aaron and team are going to be working with IT and our Vandalia Health Network team to optimize what we can until we all are on one platform, I think is the best way to say that. I'm going to go ahead and get into this last section. I don't know if there's any questions on all that because I just kind of went through that pretty fast. Let's, do you want to pause there? Does anybody have any major questions on all of that? That was a lot.
I didn't have a question, Dr. Foreman, but I did want to bring to this group. So first of all, thank you for sharing the specific slides from Cerner Millennium. So as you guys know, Cerner Millennium is the EMR that is used in the South at Vandalia Health. A lot of folks, and I can't see everyone that's in attendance, some of the folks on this call may be with our practices outside of Vandalia Health System. So some of this information that is being shared, kind of tuck it away, you know, some of the processes that we're developing in partnership with our EHR vendor and our IT team to develop these streamlined approaches, kind of tuck that away and think about it as it applies to your EHR. You know, if it's not a Cerner Millennium project or a CPSI project or, you know, Athena or what have you, just kind of tuck that away and use it because what we really want to do is share this information out to our entire network and apply it to those different applications. Another short little plug, if you do not know who your PTS is as an outside practice, please reach out to me. We can make that connection. And one of the things that we can help you do is help you pull these lists from healthy registries. You as a network partner have access to healthy registries and healthy intent outside of the Cerner Millennium world. So some of those registries screenshots that Dr. Foreman has shared, you have access to, so you can help manage your population, not just with immunizations, but all of the other quality measures as well. So if you need some extra training with that, you need to know where to go, or if you've forgotten your username or anything like that, reach out to me or your PTS and we can bring you up to speed there too. Sorry, Dr. Foreman, I'll hand it over for questions.
No, that's perfect. I have EMR envy. So it gives me hope that, you know, the goal of these things are to make our lives easier, to improve our quality, to improve our patient care. So it gives me hope that there are those other folks outside that are working on this. Hopefully I didn't butcher that too bad, Dr. Lohays.
No, you did a great job. And what Katie's saying is absolutely true, that some of the things that are being done in Oracle, the idea here is just to take the theory and find out if your EHR can do the same thing, such as barcode scanning. A lot of EHRs have the capability to do that. It's just that maybe your organization hasn't done it yet. So that's what your takeaway would be if you are on a different EHR.
Perfect. Any other questions on any of that? Comments? All right. Well, we appreciate the team effort here. All right, let's move into a slide on just some real world examples, and I'm going to open this up to others for input. Again, I think it's so important that we share. If you have tricks or tools of the trade that have worked for you over years, I would love to hear about them. I reached out to some of our pediatricians. Dr. Pumphrey was very helpful. And I'm going to give you a couple of the things that feedback that I got. Number one was to remember that the verbiage that you use, due for a vaccine versus required for school, depending on the conversation, both may be true, but where you start that discussion and where you end that discussion may be important. The other tip was that if you get a new patient that saw a previous provider, just because a vaccine is missing, don't always assume that the patient refused it. A lot of times, maybe it was a misrecord. Maybe it was just something that didn't get discussed about with the previous provider. But bring it up when it's appropriate. Don't just assume because they didn't have it and they had an omission in their record that was a refusal. And then thirdly, just because you have a conversation at one visit, this is a lot of information for us that have had a lot of experience in this. Don't always assume that because they say no at one visit. I mean, like I said, gave you the example with my patient. I pointed them towards some resources. I said, okay, I get where you're at today. Here's some resources. Please read about that. Let's talk about it again when you come back. And you can either judge from that, do you need to schedule a short-term follow-up or a more long-term regular follow-up to discuss that? So those were a couple of the tips. Anybody else have anything to share when it comes to having those tough conversations with patients?
Bonnie, I had a kind of a different approach when COVID came about, in that I kind of started explaining herd immunity to people. And because I found a lot of people thought, okay, well, I'm not very ill and I don't have diabetes, I'm not overweight, I don't have all these things that are going to put me at risk. So why should I take the vaccine? And by explaining herd immunity, when I kind of made them see that maybe we should take it for the team, that people like being team players and they could see a reason to take it so they could protect their mother, their grandmother, the child who couldn't have immunizations because they're too young, and found that was at least a little successful in some circumstances.
Yeah, that's a very good one. I think we might have used that a little bit in our area as well. And I think that's also been, I get a lot from since OB is now giving the Tdap in the third trimester, I get the grandparents that are now willing to get their pertussis vaccine because their daughter-in-law says they can't play with the baby until they do. Anything else before we move on? Any other thoughts that anyone has? This is a big, quiet group. Okay, well, don't hesitate to share or stop me again at the end or share feedback later on. We appreciate it. I'm going to give you just a few slides. I also reached out to Lisa Costello. I don't know if anybody knows Lisa. She's a pediatrician that is involved a great deal in the West Virginia State Medical Association, has a lot to say and a lot of involvement in advocacy. In general for physicians, but also as a pediatrician, as a member of the State Medical Association for vaccination. And because we probably are pivotal in having these discussions with patients, I just wanted to include just a couple slides that she had given me so you know where we're at. Again, this one's kind of tiny here. Hopefully, if you have problems reading it when it comes through on the slide deck, let me know. But I wanted you to be a little bit aware about West Virginia State Medical Association and what was going on, but I won't get too far into politics there. The other slide that she shared that I thought was important is we are a state that has strict code, but I didn't know the origin of that. So I have this little slide here. It talks about this with the title of the state code, when it was originated, and kind of how it evolved. So when we talk about removing things, I think it's good to know the origin and the history of where that developed. So I threw that in there for you to peruse. And then again, look at the date on this. This was 3/25/24. But again, I think this was a good slide that just kind of to have in your armory or toolbox, that we would now be read if this was done today, because we did have the measles case. But again, this probably speaks more to, if you look at the CDC data on vaccination in West Virginia, 96%, national 58%. It kind of correlates with who's white and who's red. So that kind of goes, just another one that goes along with that. I love this slide. I thought this was great. I'd love to blow this up and put it everywhere. And then the statement from the kind of summarized everything well from the American Academy of Pediatrics. Immunizations are one of the greatest public health achievements, preventing tens of thousands of deaths. I think we've demonstrated that. Millions of cases of disease and saving billions of dollars per decade. Immunizations are safe, effective way to protect children from disease, including some cancers, as well as hospitalization, disability, and death. It is especially important to maintain routine immunizations to prevent disease outbreaks, public health emergency, and a future pandemic. So I thought that was a great slide to end with. I have a list of references that will be included in the material. Again, special shouts out to Lisa Costello, our fellow pediatrician and state medical. Jenny Pumphrey is our pediatrician that works with us in Kingwood, and she helped me preview slides, as well as some of our other team there, and Dr. Lohace, as always. Any questions? Anything that I didn't cover? Again, we've got a great group of people, so when I say questions, you'll be asking the team, not just me.
I have a question, just something that's come up with us several different times with the clinics that we work with. How and what is best practice with following up with those who have vaccines at local pharmacies?
Oh, that's a tough one. So as far from my standpoint in Kingwood, sometimes those pharmacies report to West Virginia CIS, and so sometimes those pull into my EMR, but not always, and that's tricky. Sometimes we'll reach out and request the verification if we need to do it by a manual process. I don't know if anybody else can speak to what their process in your various area.
Some of that will come back to healthy intent through claims data. So all of us will get that if it works correctly and if we're receiving data from that insurance. Right, Katie?
Absolutely, absolutely. So anytime a claim is dropped to the payer, we should be receiving that back into healthy intent. Another caveat that I wanted to mention, so I actually had the chance to join the West Virginia Immunization Summit a couple of weeks ago, and the West Virginia CIS was actually there for one of the days. And they mentioned that they are building a more robust repository of getting information from individual pharmacies. So I expect that to get better and better with with a direct feed to West Virginia CIS from the pharmacies. So then that, of course, would help us with our connection to West Virginia CIS, pull that into our respective EMRs. So more to come on that. But I was excited that at least that they have identified that need and are actively seeking, more connections with that pool of I guess, ways to get immunized. So.
Did they mention anything there, Katie? The other problem that I have is when I have people move from a different state.
Mhm.
And I'll have somebody in their 70s or their 60s, and they'll say, well, I had my pneumonia shot, but you can't get it from their prior PCP out of state. And well, which pneumonia vaccine did you get? And,
Mhm.
and how old were you? Any discussion about, because I would love, just like our prescription drug monitoring program starting to look at different states, any
Mhm.
discussion of multi-state?
They did not discuss it a couple of weeks ago, but I'll tell you what, Dr. Foreman, I got a couple of business cards from a couple of those folks, so I'm happy to reach out and circle back to that.
Okay.
To speak on that, Bonnie,
Mhm.
this problem should be solved in the future. I'm not going to say how many years, but by the Sequoia Project, which is a national project that is similar to our health information exchange, but going national. Meaning that if you're someone who is in West Virginia and shows up in an emergency room in California, that they have a list of your medications, allergies, your problem list, that immunizations could technically be included in that list, and therefore all of your immunizations would be immediately available from every state that you receive them in. It's one repository, and it's patient-based, not EHR-based.
That would be wonderful. That would be wonderful.
It all has to do with the standards of using CVX codes and the right CPT codes for these immunizations. And as long as all of those match, that information can be shared through the Sequoia Project.
Perfect. Yet to come.
The only other thing I was going to say is that, the forecaster that we have in Oracle is a great thing to be able to use, especially in our pediatric patients. But you probably have the same thing available to you on the West Virginia CIS, because there is a forecaster on the CIS as well. And especially for pediatric patients, it's really nicely laid out, and it's really nice to be able to give that to parents, because they can see what is necessary for their children rather than you having to make the point.
Yep. And we use that a lot. We don't have that ability to always, link that interface perfectly, but you're absolutely right. And again, you just have to make sure that the information is correct, right? Is the only thing. And then their forecaster doesn't do a great job, in my recollection, of always the catch up and such, and looking for other exclusions, right? It just kind of is a really regiment, but I'm sure it'll get better with time as well.
It sticks to the CDC recommendations. So if there are other risk factors, it will not pick it up.
Yeah.
One other resource I wanted to share with this group, I mentioned the West Virginia Immunization Network. So they are born out of the Rural Health Association. They have some really good online resources if anybody needs any flyers, posters, anything like that around certain immunizations. Flu, HPV, I know are two that they cover very well. They also have a lot of flyers in different languages and things like that. So I'll make sure that link gets posted once we are able to download this recording and post that to our resources section of our website. I'll make sure that this link is posted with it as well.
Perfect. Well, I appreciate everybody joining us, and hopefully it was a little bit helpful in some way. I really like that we have this format to share information, keep everyone updated, and again, appreciate the team so much. Everything Pam's been doing, Katie, Nancy, it's very much appreciated. I think we're going to move forward in a great way.
Thank you so much, Dr. Foreman. And thank you, everybody who took time out of their lunch today to join us. Stay tuned for the next Lunch and Learn to be scheduled. And again, if you have any great ideas, please share them and volunteer. Thank you, everybody. Have a great day.
Thank you all.
Have a great
Thank you,
day.
Dr. Foreman.
Thanks.
Bye-bye.